It's 3 o'clock, so I'm going to call the Mason County Board of Health meeting together. It is January 25th, 3 p.m. And I don't know who would like to do the roll call because I can't see everybody on my screen.
I'll go ahead and do it.
Okay,
Roll call, Carrie Gardner,
Aye, Captain.
Sharon Trask,
Present.
Kevin Schutte,
Here.
Peggy,
Van Buskirk, I'm here.
Carrie Davidson,
Yes, I'm here.
Diane Zorn.
Which is Mackenzie, I think.
Okay. Okay, Mackenzie. I don't see Mackenzie here yet.
That's Diane.
That's
Oh, okay, Lydia Boucher,
Here.
Randy Netherland,
here.
Derek Allen. Or Diedrich, excuse me.
Diedrich.
Diedrich.
And Lydia, is David not here?
You should be.
Oh, I just didn't see him.
I haven't seen him yet.
Okay.
I was just on the phone with him a minute ago.
Yeah, I know he's planning on being here.
Okay,
How many more do I need to?
There
do I
he
need
is.
to Do all of them?
okay. And I know Alex is on, and I saw one public, which is Jean Bray.
There's
So,
David.
I would like to request a motion to approve the agenda.
So moved.
I'll second.
Any discussion? All those in favor, aye.
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 Okay, so the next is a action item to approve the resolution of dates for meetings for this year. I'm assuming everyone went over that. Is there any discussion or can I have a motion?
I'm sure I move approval of the resolution setting the meeting dates as outlined.
I'll second.
Okay, any further discussion? Hearing none, all those in favor? Aye.
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 Okay, so the next action is election of officers. Or actually officer, the chair. So are there any nominations for chair?
I have a clarifying question. How many years can we have a chair assume the chair position?
I don't know, and I think that's maybe going to change. It's stated that they do it for a year. But we're also discussing the makeup of the board later, so I'm not real sure.
So what it says in the bylaws or by ordinance is at the first meeting of the Board of Health, members shall elect a chairman for the period of 1 year who may be any one of the 3 commissioners. So that itself is old.
Yes. Because we discussed, we said it before that it could be more than just the commissioners.
Right.
Because we had a problem with sometimes no commissioners being there.
Right.
But that was years ago. So I don't know. Any further discussion? Would anybody like to be a chair?
Well, I would like to nominate Peggy again for 1 more year.
Second.
I don't mind doing it. With being Zoom, I've saved a lot of gas money, I'll tell you. So any further nominations? Okay, all those in favor?
Aye.
Aye. Aye.
Okay, I guess I'll move on then. I was gonna turn it over to somebody else. But we'll keep going. So can I get a motion to approve the minutes from November 2021?
Madam Chair, I move approval of the minutes for November 2021 as presented.
I'll second that.
And any discussion? Hearing none? All those in favor? Aye.
Aye.
And I didn't hear, I guess I should say any opposed. None, so it approves unanimously. I just heard all the voices, so I guess I just assumed it was none opposed. Okay, so Carrie, Health Officers Report.
Thank you, Madam Chair. The first item I wanted to address is the composition of the board, which we will be coming up to later. I was requested by Commissioner Schutte to find a position to sit on the Board of Health. We have at least one and perhaps more candidates for consideration of the board. Second item, I wanted to speak clinically to the board about the Omicron variant that I've been seeing. As you may all remember, I'm an emergency physician. I'm still not credentialed at Mason General, although I'm very close, but I've been working in California and Utah really much more than I want because the physicians are also getting sick with Omicron. But the good news is that I have only hospitalized one person out of really more than 100 that I've seen that have Omicron. So I think that's really good news that even though it's spreading like wildfire and it's certainly increasing our numbers, that it's not nearly as dangerous as Delta. The unfortunate thing is that because the spread is so much greater, on the order of 1 to 2 orders of magnitude, our numbers have gone up. That even with small numbers of people needing to be hospitalized, we are still seeing increased hospitalizations. The Delta burden is still present in the hospitals. So as a result, hospitals remain overfull and transferring patients for care remains really problematic. And because of that, I would like to make another plea for folks to consider getting vaccinated. And if you're already vaccinated, to get boosted, because even if it's small numbers of people getting really ill, the hospitals are simply not capable of handling more sick people, especially with prolonged hospitalizations. As you may have also read, Omicron, we think, will be peaking and maybe already has peaked locally and will start dropping off. Now we're at a very high rate, so that doesn't mean that we're going to see small numbers of people infected over the next few weeks. But instead of seeing over 2,000 people per 100,000 people get infected every day, we're going to see on the order of thousands, 1,000 plus. And then hopefully we will drop back down into triple digits instead of quadruple digits. Omicron has spread like wildfire. The variant called BA2, if you're having trouble remembering the letters and numbers, you can call it son of Omicron. It's a variant of Omicron, and it is now the predominant form that's taking over in Europe. We don't really have data on whether it is more or less infectious or virulent, in other words, making people sick. But we do know that right now, circulating in England, it's 50% of the variants that they're seeing. There are, of course, multiple types of Omicron, and we haven't figured out whether there are certain types that are making people more sick than others. So that is all still to be determined. There was an important statement just released, I think today, by the National Association of County and City Health Officials. It's a joint statement with several other large public health organizations, and they are recommending that we stop doing contact tracing. And this is a really big deal that they have made this recommendation. The state of Washington has not yet determined whether they will follow along and support this statement or not. It just came out yesterday, so we really don't have any, we haven't had time to process it through the Department of Health. Dave and I have talked about this, even in advance of this being released. We're of the feeling that we are at community spread where contact tracing really loses its value. So we have not made a decision yet about whether to recommend to our local schools. And the reason is because messaging has been so difficult during COVID. We want to make sure that we are acting in concert with our other local health jurisdictions. But I'm happy to take any comments from the board. We are inclined to recommend stopping contact tracing, which would of course be a huge bonus to the schools who have had to spend a lot of time doing that. And so I think the last thing that I wanted to comment on is we are really looking forward to getting back to the basics of public health, which every time we try to take a step forward, it feels like we get slid back 2 steps by the latest version of COVID. So for that reason too, I would like to request that people get vaccinated, because the sooner that people are immune to COVID and not getting hospitalized or going to the emergency department to be evaluated, the sooner that the public health system can get back to the foundational public health activities that we're really desperate to get back to. That's the conclusion of my report, Madam Chair. Thank you for the floor.
Thank you very much. Are there any questions for Carrie?
I have just a quick one. Carrie, so there's also something going around, I think it's the Rona flu or the flu Rona.
Yes, so we are seeing people co-infected with both influenza and RSV. And both of those complicate the body's ability to not just respond immunologically, but also to respond in order to support normal health functions like breathing and maintaining your temperature, maintaining your hydration status. So when we say flurona, we're saying that people are co-infected with influenza, that usual seasonal flu that we see, plus coronavirus. And I've seen a lot of my patients infected with RSV, which is respiratory syncytial virus. And that is the wintertime plague that attacks children and tends to hospitalize infants because their airways are so small, and RSV creates a lot of mucus that clogs up their airways and can cause a life-threatening hypoxia in infants. We don't seem to see that kind of hypoxia in adults, and we're not seeing the hypoxia with the Omicron variant. It's not appearing to attack the lungs nearly as aggressively as the Delta variant did. I don't know if that answers your questions, but flurona is certainly a fun thing to say.
Okay.
It does, thank you.
Okay, any other questions for Carrie? Okay, I guess Dave, you're,
We had a quick question or
okay.
clarification. I was looking and it does look like there is a specific vaccination clinic at the casino this Friday for age 5 to 11. Is that an outside group that is doing that, or is it open to the community? It is. Is that something that people are aware of, or?
Not one that I had heard of.
It's listed on the website that shows where you can get vaccinations. And it's here in Mason County.
Okay.
And so since that is school-age children, I wanted to get some clarification on maybe who was doing that and if that was open. So if anybody could get back to me, maybe that would be great if you get a chance to take a look at that. I couldn't tell from what was listed.
Okay. So Dave, are you going to get back to her, or do
It
you?
looks like Lydia's on it right now, so.
Okay, good. Sounds good. So I guess you're up, Dave.
Okay, so I'm following along with Dr. Gardner. Omicron, where are we? We're looking at, like she said, it went like wildfire, or I referred to it like a space shuttle launch. I mean, this just went straight up. We are starting to see possibly the peak here in Mason County. It's starting to turn around a little bit. In Western Washington, we are seeing it starting to come down. Eastern Washington is lagging behind. So if it holds true to the pattern, figure another 3 weeks, we should be down quite a ways. We'll see. It's acting different than Delta, and the Delta went up slower. It took longer for the peak to come off, and then it kind of hit a plateau and just kind of bounced along. This is not that. So this is acting in a different way. And hopefully it drops back down. Testing. So we have ordered tests. We've gotten some tests in. I've placed a large order with the Department of Health, and as has every health jurisdiction out there. And we're waiting for our notification that our tests are available. Shipping has been a problem. I did talk to him and say, I have a pickup. I will come get the tests at the warehouse if that's what's necessary for us to get our tests. So, and they kind of poo-pooed it. And then the next day they're like, you know what, that's probably not a bad idea. We may set up a will call. So when your tests are available, just come over with a pickup and pick them up. So that's kind of where we're headed next. So I did order 20,000, an initial order, and another order of 20,000 after that. So this morning we've been working on a distribution plan. I've made a few phone calls around to folks. I've talked to the commissioners about, you know, who to include on the distribution plan. We should have that firmed up a little bit more by tomorrow. My intent is once we get the test kits in to be able to put a list out online, all kinds of media, say, if you want to test, here's where you can go to get the test. And make those available through businesses, through our other partners as well. The schools have their own pipeline that they're accessing, and the tribes have their own pipeline. So the priority for us really is our most vulnerable populations. So those folks that are non-English speakers, no access to internet, those sorts of contingencies. We're going to push those out to, for example, food banks, places like that, where we might intersect with those populations. So we're going to be pushing really hard on those lines. And then when the second order comes in, we'll shift more of the focus to businesses, but we're initially going to get that stuff out to our vulnerable populations. So I don't have a timeline on it. We want to be ready. So as soon as it hits the ground, we're out with it. Along with that distribution, we are going to include N95 masks. We have the ability to order a one more N95 mask per person for the county. So what we're going to do is take our current stockpile, push that out because it's all dated. And then when we get the order in from DOH, we'll replenish our supplies in our emergency response trailers with the new supplies. That way we freshen up what we've got and still manage to get stuff out. I did send out some of these really, look at a little bow tie. It's an N95, it's for kids, it's about this big. And it unfolds. And I sent that out to a school yesterday to see if their kids will wear them because they're kind of snug. But they're pretty good masks. And if they're liked, we'll get some more of those and get those out. I've got about 300 of those, and we can get those out right away and get those kind of out of our stockpile as well. I have a whole bunch of the old duckbill ones that nobody wants. We'll stick those out there as well. And if you haven't seen it, it really does. They're orange and they're shaped like a duckbill. They're called the duckbill N95s. We'll get those out. So testing and N95s are coming as soon as we can get the test kits in. We have a change in the Washington data dashboard. So if you go online and look at that, it's a whole new look. We've really been encouraging people to go to the data dashboard to look up data for themselves and come to their own conclusions on things. It's a new look. It's a little more user-friendly, I think. One of the things we're seeing, though, is DOH is only going to report 3 times a week, where they're reporting right now 5 times a week. It's going to go to 3 times a week. So we're going to work around how we're going to report that back out to our public. We're probably going to go to, Monday, Tuesday. They're going to report Monday, Wednesday, Friday. So ours will probably be Tuesday, Thursday, Monday. But really that Monday report is going to be kind of dated because it's really what came in on Friday night. So we're going to talk about that tomorrow morning at Area Command and see what we think as far as reporting goes. And then something on my mind, and Lydia may come to this about, and Lydia, just nod your head, WIC and family planning. Were you going to talk about that at all?
We're going to talk about that when we talk about the CHA.
Okay, all right. I will leave that then because that is a concern of mine, and it's going to be represented in the CHA as well. We'll be coming back to House Bill 1152. We'll talk about that in a little bit. And I want to talk about regionalization. That's right. So earlier today, actually for the last couple of days, I've been talking with the Chief of Staff for Department of Health about regionalization, and that program has just been given to her to operationalize. We had a very long conversation today about it, and she has offered to next week. She's presenting today to her executive team and then to the governor's office this afternoon what her thoughts are on this. And then she's volunteered to come over to Mason County next week, sit down with me and Commissioner Trask and walk us through what DOH's thought process is on this, take our feedback, and then Commissioner Trask can take it back to WASAC through the Ledge Committee, and then I can take it. I'm the current chair of the Executive Leadership Committee for Wasalto, so I can take it back to our group and talk our group through what DOH is telling us is their plan. So this year they had, I think, $130,000 to implement. Next year they've got $1.8 million to implement. So we have some concerns about that, and we're trying to make sure that this is not getting into local public health or circle. One of the things they had talked about was, well, we'll work with your hospital systems so you don't have to. Well, that's not something public health at the local level wants, somebody from outside to do. We will take care of that ourselves. Thank you. So that's what a large part of this conversation is going to be about with DOH here in the next coming weeks. They're going to reopen House Bill 1152, which authorized this, but not this year. They'll reopen it next year. So we've got some time to kind of work through it with the chief of staff and maybe come up with something that's usable, and then have a good recommendation by the time we come to this time period next year when that gets opened up. And then fiscal. So DOH and local public health have had a process called the Consolidated Contract, and we've been doing this con now for 30 years or more. Consists of 3 parts. You have the recitals, any contract. Then we have a statement of work, which is Exhibit A, then Exhibit B are all the financials that are attached to Exhibit A. And Exhibit B is the piece that we generally present. Well, actually, we present the whole thing because it's a contract, a consolidated contract, and the commission signs off on. They've gone with a new concept called the deconstructed contract. So in December, we got the recitals, and I signed off on the recitals because it's identical really to what we've done in the past. This month, we've got the statement of work, but we have to go out onto their website, pull it down from their website, incorporate it. Now, that's not our whole statement of work that's out there. I found out today what's on the website is just anything that has a change to it. The things that were rollover from our current or last fall's contract won't be available to us until February. And then we'll have the financial piece attached to that in February as well. We got a piece in today, and Casey's working on trying to take all the pieces, put them together and back into a consolidated contract, and we'll bring that forward to the Board of County Commissioners. But I wanted the Board of Health to understand that this process got much more complicated, and what it does to us in operations is that the longer it takes to approve that contract, that's if it takes a month, 2 months, or 3 months, which is what it's looking like it's going to take, that's 3 months of time we can't spend money because we can't back bill to a contract that we don't actually have signed. So, and it's what happened to us last summer. We were approved for funding for Foundational Public Health in July, but didn't receive the contracts until November, and then had to kind of rush it through. So we got about not even 2 months of spending on that money. And then we're asked already last week, please tell us how much of the funding you're going to have left on July 1st so it can be reallocated. And it's been very difficult. So we had quite an interesting discussion about that as well today with the chief of staff about how difficult this process is and what it does to those of us, especially in county government. It's maybe a little bit different for districts because they have rollover funding that they can access that's not the same as how county departments do business. So there's just a lot of turnover and a lot of change at DOH that we're trying to get our heads wrapped around here locally because it does affect us, how we operate and how we're funded. So I just want to bring that to the board's attention. So later on in the year, if they say, hey, how come you're giving all this money back? Well, it's because we weren't able to access the money because of the bureaucratic process that we're being stuck in. So, and with that, I think I'll call it good.
Can I jump in and answer Carrie Davidson's question? Yes, it's Friday, the 28th from 10 to 5 at the event center at Skookum Creek. It was advertised to the schools. They were sent it out on the 20th of January. It's been on Facebook. They're putting it out again, Spanish and English. It's for all ages. It's not just children. It's any vaccine age. And you can register when there's a registration.
So who's doing
scan.
the clinic?
It's being
Mhm.
done by Community Health Plan of Washington and Choice Regional Health Network and Family Education Support Services. Group of
Okay.
people.
Thank you.
Uh-huh.
All right, that's good to know. Thanks, Lydia.
Anything else, Dave?
I think that's it for me until we get to House Bill 1152 discussion.
Right. Okay, so Alex, you're up.
All right, good afternoon, everybody. So I've got my report there for you. Sticking with what I did last year and kind of giving you guys a summary of 2021. We spent January pulling up all sorts of numbers and providing them to DOH and all of our other agencies that need it. So I figured I'd give you some of that. Some quick bullet points over it. Permits are obviously up. Most of that was seen in the first 6 months of the year. This last 6 months, things have leveled off a little bit, but overall we did finish higher than last year. And again, most of that's tied to sewage and drinking water with our economy and just the overall building of everything going on in Mason County. So our food safety saw some staffing changes with Kayla Holmes' resignation. And then we also got some foundational public health money, as Dave has expressed to you guys many times. And that did get in place in December when we got that contract signed. So we did bring in some extra staff to help out with food safety. So we're excited. We've got, Mason County has had one food safety specialist for as long as I've been here. And so we're having 2 staff on board. We're excited to bring some more educational elements and things into our food safety program. Water quality funding, we've got some local funding support this past year. And so this year and then 2023 probably too, we're kind of going into a transitional period where we're wrapping up some of the grant projects we have and kind of moving towards utilization of this local funding. And so we're excited about that. And we've got some changes to come and we'll keep you guys apprised of all that. Any questions on my report or programs in general?
None from me. Looks
All right.
pretty good.
Well, I'll move
noticed
on
there
to our.
weren't- I noticed
Go
there
ahead.
weren't as many rabies tests. Quite
Yeah,
a
our
few less
rabies stuff,
rabies.
our rabies stuff kind of goes up and down year to year, but yeah, we did have quite a few calls and cases to work last year than years past. So I shouldn't guarantee, that'd be bad, but we'll probably be dealing with more calls this summer. It just seems to be the pattern that we follow with vector
Right.
for some reason. It kind of goes up and down, but yeah.
Okay,
Right,
so
well,
then,
I'll move to our chapter 632 updates. Okay.
okay,
So we are proposing updates to chapter 632. This is our plating standards. In these rules, they address our health requirements when it comes to subdivisions and division of land and plating. So this chapter was last updated in 1980, 40 years. I think it's
time.
good reason to propose some updates for you today. But overall, a lot of these requirements are being addressed at the state level now. So there's a lot of strikeout on here. Some definitions are getting updated. We're adding in some language around general requirements, what forms and fees are required, just to provide some transparency with the public on what our processes are, and also give staffing that backing. Whereas if the public were to question some of their actions, we can revert back to code and say, this is what we're doing. So overall, it just brings the chapter into compliance with our state regulations and what we're doing currently. So I'm proposing this as a Board of Health approval today, and then we would move it to the commission for a public hearing and adoption.
Okay, did everyone get a chance to look over what Alex sent us? And if so, are there comments? I like that it's a lot simpler with using the the WAC codes instead of having to have all our own.
Yeah, it's less confusing too, and we have our chapter that's outdated and the state chapter that says something
Yeah.
completely different too.
So can I get a motion to pass this on to the commissioners, or do you feel comfortable doing that? Anyone?
I'll go ahead and move that we approve the updates to chapter 6.32, the plating standards, and move that to the Board of County Commissioners.
I'll second.
Any other discussion? Okay, all those in favor?
Aye.
Aye.
Any opposed? Hearing none, it moves forward. Okay,
Great, thank you. That's all I had.
so
Can I-
Lydia. Oh, go ahead.
Sorry, can I ask David a question real quick before I forget?
Sure.
Where does the public pick up the test kits and the masks?
So I'll publish that as soon as we get the test kits in. So we did an allocation for Shelton, Belfair, and Hoodsport in a broad way. And each of those locations will have like food banks, libraries, PUD, any number of locations. We'll put that out so people will have someplace convenient that they can go. They
Okay.
also have the ability to get them from the feds on the USPS, the postal
Right.
website. And then the state has a website up as well. And those are fast. I mean, a minute and you've got your thing on order. So
Yeah. Okay. Thank you.
you bet.
Okay, Lydia?
Hello. So first of all, the November, December manager report that all my staff put together through all their pieces is there for you to review. Kind of an update of what's happened the last couple of months. And then today I want to leave plenty of time because we have two staff that are going to be presenting as well as a guest that's going to be presenting. We're going to start with Abe Gardner, who runs our behavioral health work. And Abe, if you don't know yet, is leaving Friday, will be his last day. He will be moving on to the north end of the county to work. We're sad to see him go. He has been a wonderful contribution, done wonderful contributions in the county in behavioral health for the past 5 years, and very sad to see him go, but understand. And he's going to be presenting, kind of giving you an overview of what's been going on the last 5 years, where we're at, where we're going to next. Part of his presentation is also Lucky Anholov is going to be presenting, who was our researcher for our COPE project that we've had the last 4 years. And he's going to be sharing some of his data and information. And then after that, Melissa is going to be presenting our community health assessment and sharing that with you all. So they're going to do some PowerPoint presentations. Abe, I'm turning it over to you.
All right. So I'm going to go ahead and share screen here. Can everyone see that?
Yes.
Yep.
Terrific. Okay, so yeah, so for those that don't know me, my name is Abe Gardner. I work at Mason County Public Health for a few more days here. But what we wanted to do is give an overview of our behavioral health response over the last 5 years. And so we worked really hard to try and put 5 years into 10 slides or so. So we'll see what we can detail here for you. And if you have any questions, please feel free to ask near the end there. And Lucky's going to jump in after a couple slides to describe the work that he's helped us out with. So when we reference behavioral health, we're talking about substance use and mental health. One of the things that we've really prioritized at Public Health is taking ownership of what it means to be a backbone organization. And I think that our work in the behavioral health response has really epitomized that. We've really worked to break down barriers and encourage our community partners to communicate and to work together and to partner. Being at Public Health, we have the opportunity to kind of look at things as a system. There's not really a monetary gain for us at Public Health. And so it is our gain to see the system work as a whole. And so we've really worked diligently over the last several years to take ownership of being a backbone organization here in Mason County. We've also prioritized the need for centralized resources. When we first started our work a few years ago, we heard it loud and clear that with as many resources that change, with agencies that show up and then are leaving, and funding sources change, and names change, that kind of thing, it was needed that there were to be a way to communicate an up-to-date and accurate kind of centralized location for that information. So we came up with what some of you may have seen are our behavioral health resource guides. I don't know if you can see that, but we have those that are utilized in our community. And we also put together healthymasoncounty.com. If you haven't been to healthymasoncounty.com, I really encourage you to do so. It has a ton of information about Mason County. And in reference to behavioral health, it has resources, so for substance use, for mental health, recovery supports. It's got a link for our law enforcement assisted diversion program and all kinds of other stuff. So if you haven't checked that out, I really encourage you to do so. We've also worked to prioritize the utilization of data. And we have several different data collection projects in place. And the COSAP or COPE project is a great representation of that. And that's what Lucky's going to share on here in just a few slides. But what this data has allowed us to do is it's allowed us to encourage a lot of our partners to engage in conversation about solutions to some of the difficulties that we're seeing in the data. And it's also helped us to identify gaps and look to address those gaps, find barriers and really break down those barriers. So it's helped us write and receive grants, and really has helped us move forward in a lot of our programs in Mason County. You'll notice a theme also as we move forward here that participation and collaboration are really at the center of a lot of the work that we've done. It's represented in the number of MOUs, formal MOUs, and letters of participation that we gathered years ago at the beginning of our COPE and COSAP project. We actually have 26 of those on file of different agencies throughout Mason County that were willing to engage and that were willing to put forth effort and support towards building out our behavioral health response. It's also represented very well in our stakeholder meetings. The participation there continues to be at a pretty high level, even years after the beginning and when it started. And we've had several different community forums, and there are a number of coalitions that continue to run very strongly. Another very important element to our behavioral health response over the last several years has been community education and stigma reduction. As you know, when we're talking about substance use disorder and mental health, there's a lot of polarizing and sometimes difficult topics. A lot of folks have, whether it be personal experience, they have family members, and there's a lot of emotion that runs deep when you talk about these particular subjects. And so what we've really worked hard on at Public Health is bringing as much education to the forefront as possible, and talking honestly and openly about some really difficult topics. Talking about what harm reduction is, and how it's beneficial to the individual as well as the community. What is recovery and how has that changed over the years? What is the data telling us? How is the science helping? How is it changing? And peer support. What is peer support? And how does that help individuals? And how does that help what has been done in the past? And how can that change moving forward? And of course, overdose prevention, Narcan distribution, and what that looks like for our community. Being a small community, we've had to be creative, and it's really helped to be consistent as well. Making sure that our messaging is consistent, and utilizing every media and messaging outlet we can. You'll see there we've ran ads on local radio stations. We've utilized the newspaper. We have some slides at the movie theater. If you're sitting there, if you get there early before a movie, you'll see we have a couple slides that show up. Utilizing social media, local media and service clubs, and of course word of mouth. Every chance we've gotten to do a presentation at some of the service clubs, we've jumped at the chance, and not only communicated what we have going on and what programs there are, but also answering questions and having some of those difficult conversations. And I think that's really helped move our response forward. We've also had awareness events. I think one of the main ones that everyone here knows about is our overdose awareness walks. Those have been received pretty well by the community. We've had incredible support from the commissioner level on down, and they have gone really well. And I believe that's probably an event that's going to continue for years moving forward. So moving into these next few slides here, I just want to highlight a few of the programs that we have in place in terms of what we've done to build capacity and improve the system that we have. Our efforts really started 5 years ago with the Washington Prescription Drug Overdose Program, the WAPDO program. This is where we created a surveillance process for law enforcement entities, our fire and EMS, and our hospital district to report overdoses so that we could collect that data and work to follow up with individuals that were survivors of overdose, and look to connect them to services and distribute Narcan kits. And this is also where we began building community relationships, and where a lot of our work started. The next program that was kind of born out of that is our comprehensive opioid stimulant and substance abuse program, COSAP program, which started out as COPE. And this program kind of had two elements. One was the ability to really kind of focus on our systems approach and looking at gaps in our current system and pursuing avenues to fill those gaps. And then the other piece of that was our data collection. We engaged with several community providers that willingly and by their own accord collected data for us. And we have several years of data that we collected, and we were able to put together a bit of a paper and report based upon that data and information. And that is what Lucky is here to do, is present on what that process looked like and what were some of the findings. And so before I move on, I'm going to, whoops, apologies. I am going to stop sharing screen so that Lucky can jump in for a couple minutes.
Good afternoon, everybody. Can you guys see my screen?
Yes.
The sun finally came out at the most inconvenient timing, but thank you for having me today. And I will basically give you an overview of the work that I have been doing with Abe and Lydia and Mason County Public Health and all of the supporting organizations, and the effort that went into fulfilling some of the needs that we had identified and what my role was as the individual who's responsible for research. So some of the goals and objectives, strictly speaking, for the grant itself was to be able to focus on preventing opioid, stimulant, and substance misuse and abuse, and basically providing improved effectiveness in response and creating better strategies through the collection of data, sharing of data, and data analysis. So our data was, the collection process was very unique, and because we tried to identify data at two levels. First is the client level. Those are the individuals that are coming to all of the agencies with various needs for support, for treatment, for recovery support services, and any other assistance to help them navigate the challenges they're experiencing. So at the individual level, the data collection is difficult because this is a lot of sensitive information. So we had to develop a sensible protocol that allowed us to get us understanding of who the individuals are without collecting data that is unnecessary, but wanting to understand the scope of the problem. So individual level data was important, and we were able to develop an instrument and a protocol that allowed us to get an understanding of the individuals who are impacted by that pandemic in the community. Second, we wanted to see how do the actual treatment and service providers interact with each other? So we have data at that level, being able to talk to the particular agencies to understand how they refer clients, because this is not a problem that is going to be addressed by a singular agency. There's going to be a need for very extensive coordination and relationship building to be able to really structure exchanges that would allow all policy arenas to engage. This is not going to be just health. There's going to be behavioral health. There's going to be mental health. There's going to be law enforcement and other agencies that will be needed as well. So we have data on how the agencies are working together and what are the potential gaps that we can focus on going forward. And again, the goals was to have an understanding of how big is the problem in Mason County. There's data that indicates that rural counties are particularly hard hit by this pandemic. So wanting to know what the scope is, knowing, having an understanding and being able to contribute to that understanding was important, and improve our knowledge of the network and the systems that are involved in providing support to the individuals that are experiencing that pandemic. So as we developed our protocol with the supporting agencies, we were able to generate a unique identifier for individuals that we can then track. So we were able to track how many individuals, unique individuals, are able to access the system. And over the course of, since we started collecting data, July 2018 until June 2021, we have over 2,100 individuals, unique individuals that have sought support or treatment with the providers that we're working with. And a substantial chunk of these individuals are male, so 70% are male or identify as male, about 30% identify as female, and less than 1% identify as trans. The age distribution, we were able to collect data in age ranges to be able to provide for anonymity of participants. So about half of those individuals are under the age of 35, sorry. And they're referred to a lot of recovery support services. So what we are able to see is that on average, individuals need quite a bit of support to be able to successfully tackle the challenges they're facing and no longer be needing the services or medical treatment or other treatments on their successful recovery, on their successful journey. On average, what we saw in the data is that individuals needed at least 1.3 services, and those are coming in a different categories. Peer support was very popular, but housing, medical or dental, transportation, education, and employment were frequently recommended or prescribed is not the correct word here, but those individuals were referred to those types of services, or those were the needs that they expressed that they had. So being able to work with agencies that provide the work in those policy arenas is really important. And that coordination is essential because it is not going to be just providing one of those services and expecting individuals to be successful in their journeys. The recovery support services and the referrals to other treatments were what we're really focusing on. And the referrals were low in our data. We had hoped that we see higher levels of referrals, but we see that about 25% of those individuals are referred to support services, and many do not return in our data. What this means is that over half, 55%, if they do not return, there's two possible explanations for this. One is that they received everything they needed. They received shelter, they received transportation, they received help with their resume, they have work, etc. The other explanation is they found the system unresponsive. That means that they were referred to services and either those were not the services they needed or those services were not provided in a way that helped support that individual. Our data does not allow us to answer these questions, but it allows us to identify that there is a need there to dig deeper, to get more data and find out what happens with the participants that exit the network of providers that we have. And this is a limited network that we have MOUs with, but we are hoping to expand this going forward because it is going to really help us understand how can we better serve individuals that are experiencing crises and various events, and how do we better support them as a community? So that was something that was interesting in our data, and we also were able to identify what is the process associated with discharging an individual from treatment or other service that they're receiving. And we see that when it comes to the discharges that we have on file. And again, the data collection process is daunting, and we're very appreciative of all the agencies that took time to fill out the paperwork, because while they are seeing the individual and providing the services and support that they are providing, they're also filling out paperwork for us that allows us to understand who the individual is and what was the service and what was the process that they went through. So individuals that get discharged from treatment or services, an overwhelming number of them, say over 65%, they do not complete the programs provided by the agency that they're discharged from. And if they do not return, we have a hard time understanding why. Some, there's explicit reasons: moved out of town, moved out of the county, moved to a different area, no longer needed services, not the right program. We have evidence that that is a substantial a reason for people not to complete services, but it's not holistically the only reason. And there's a number of individuals that get discharged and they return at least once in our system. So we have individuals that we see frequently. And when I say individuals, we see an identifier frequently show up, oftentimes going to the same agencies repeatedly. That means that they are comfortable going to that agency, they're receiving support, but they're not able to exit successfully. They're not able to overcome the challenge that they're facing. So they're constantly in need of support. And there's a lot of those individuals that we do not understand what is missing. Only 14% successfully complete after we have seen them multiple times in our data set. Only 12% are referred to support services. And there's an overwhelming chunk of other that we do not know why. And this is, again, a greater need for data collection going forward. And our referral process, data gathering, basically, we were able to find out how do individuals enter the system. So when they interact with a treatment or service provider, whoever is doing the intake would basically note, how did the person get there? Did they walk in themselves? Was that the referral process? Did a family or friend refer them? Was it legal, or was it another agency? Something that was fascinating over the course of this project since 2018, since I've been involved, is that the number of other agencies grew exponentially. It initially started with just a handful of agencies that we had MOUs with, but then it grew. There were other agencies that were looped in, that were providing referral for clients, which was really, really interesting to see. And again, very encouraging. That means there was evidence that something is working here. Other agencies wanted to be involved, and that was something that we found is positive. But again, we need more data to be able to understand how do the processes work. And I'll give you a couple of examples at the individual level of what we were able to see in the data that was, in a way, worrisome, but it provides a picture for greater need for that type of work. So what you're seeing in that table is in the columns, you have individuals in terms of when they encounter the system that Abe is going to show you a visual with, how the referral source, what type of treatment was provided, whether or not they were referred to support services, whether or not they were discharged from the program they had entered, and if they were referred somewhere else for additional treatment services or other programs, and if they've completed successfully that particular program they're in. So we have an individual who walks into an agency, they receive MAT, they're referred for a housing, medical, and dental. So those are recovery support services that they are needing. They're discharged. They don't complete the program because, again, there's additional support that they need. We don't see them again. So they do not return in our data, and that means that potentially they did not receive the services that they were hoping to receive, or that we just don't have an entry form for them, which is, it could be, it's also plausible because, again, that data collection process can be very burdensome to agencies, and it's very difficult and requires a bit of time and effort by a backbone agency to go and acquire that data. The second example, the referral source is another agency. The client receives outpatient treatment, they're referred to mental health, they're discharged, they're referred where they can go and get mental health. They do not complete this particular agency's program because, again, they need mental health more than the service that they were admitted for. We don't see them again. So we don't know if that person attempted to get the mental health help that they were supposed to get, or if they did and we just don't have them in the in the data. So another example, again, similarly referred somewhere, and it appeared so the client then appears with the second agency where they're referred. So there's an attempt to communicate with that client, but they're not able to contact that client, and we do not hear from them again. So I will skip through the last couple of examples and get to from the individual to the network level data. All of this work up to this point gives us an idea of how do the clients experience the communication by the service and treatment providers. We also went with Abe to all the service providers that we're working with and asked them questions regarding who do you talk to? Who do you go to for resources for? Who do you have meaningful discussions about solutions with? And what this data shows us is that, again, the referral processes and the communications between agencies has grown substantially, but there's a lot of room for improvement. And yes, we had interactions with COVID that were challenging, created a lot of disruption in the way that agencies do work, but also in the way that individuals experience various events. What we saw on the left-hand side, you see the resource network is much larger than a discussion network that we have. And this is not surprising if we think about it in terms of the effort that goes into creating those collaborations and coordinating exchanges. So the yellow circles indicate that that particular agency or one of those yellow circles was identified by at least 2 other agencies in our network as somebody they go to resources for. So in a way, they were, when we asked somebody, who do you go to get information about COVID immunizations or vaccinations? Then they say, we go to public health. We have 2 of those, confirm this, that becomes a yellow circle. On the right-hand side, you see the discussion networks. So it is not just who do you go to resources for, but do you have a conversation about how do you improve the services? How do you improve the connections? How do you make sure that those individuals are successfully navigating the challenges? That network is much smaller. And again, this is reasonable to expect because those types of discussions and those types of coordinations require more effort, requires more time by individuals, requires exchange of resources, and that is difficult. That means that there need to be additional resources. Now, all of that work we put in the report, but also to give you an idea of how unique the work has been with Mason County. We were invited to actually submit our work for publication in the PA Times, which is the magazine for the American Society for Public Administration, on their special issue for COVID and public service during a pandemic. I had presented this work at a national conference, and we have a unique data set. When Lydia and Abe and I watched all of the presentations for other agencies receiving the COPE grant, I was able to identify that we have a data set that nobody else has, which is a tremendous opportunity, but also got national attention from Mason County. So we were able to publish, we were invited to publish our piece. And again, this is a national magazine for a huge association of public servants, and Abe and I are co-authors on the piece on page 36. So in addition to that and the conference presentation, there will be additional academic papers that will be generated from this work, but also hopefully ASPA, the American Society for Public Administration, has expressed an interest of inviting us and supporting a webinar where we can tell the story of Mason County, because we are the smallest COSAP grant recipient, and we are arguably better positioned to tell a compelling and successful story because of the effort in this community, the way that everybody came together, and being able to see how those stakeholder groups have grown. At every stakeholder group that I attended in person prior to COVID, the tables got bigger and bigger and bigger because people had recognized that this is a fruitful and effective way to tackle a problem that is not a singular solution. So hopefully this work continues. What we identify is that there has to be a better coordination between the agencies to prevent those individuals from dropping by. Unless we know for sure that those individuals are getting the support they need. And that's why we don't see them coming back to the system, which is probably not the case for a lot of those individuals. Sustained data collection is essential, but that requires effort. That requires a policy champion that is promoting innovation, such as the data collection process that we have, and a backbone agency, because Abe has done a lot of work going from agency to agency to agency, collecting all the data, right? And gently nudging all those treatment and service providers to really stay with it and give us that data, because now we can tell a compelling story and identify the gaps that we need to work for. And again, that requires support for those agencies because resources are tight. And with this, I will end my presentation, and I'm here for any questions you might have as well.
Any questions?
Just a comment real quick, man, that
Yeah.
presentation was amazing and full of information that I'm sure that a lot of us can use. So thank you for that. Thank you and Abe, great partnership, great presentation.
Yeah, I would second that. And I guess my question is just is there a chance for us to get copies of the slideshow from both of them, both slide decks, to take a look at?
Yes, and we also have the papers and an executive summary paper to go out to you all.
Oh, that'd be fantastic.
Great.
Yeah, definitely.
Finish it out
Yeah.
real quick, if that's okay, Peggy.
Yeah, I think we have time.
Okay, I'll be quick.
Go ahead.
Okay, so quickly, when we're referencing the system, we put together a visual of what that looks like. And if you'll notice here, we've got entry points, services received, recovery supports. Down here, we've highlighted needed kind of point of emphasis that we identified several years ago, in that there was a lack of care coordination and peer recovery. And so we put a lot of effort into building up that particular part of the system. You'll see there's numbers in some of the boxes there that references this next slide. These are the resources in the community that are provided and that are at each point in the system. You'll notice the ones that are highlighted in red, those have been added. Those are new since 2017. I believe there's close to 16 or 17 of those. So you've seen that the system has definitely grown over the last several years. So in addition to the WA PDO and the COSAP projects, which have both been completed. Wanted to highlight, so the OD2A, that's the WAPDO program kind of morphed into what is now the OD2A program and grant. A couple data points I wanted to share is that within these two programs, we've been able to distribute over 2,500 Narcan kits into the community. Every law enforcement officer has been trained and carries a Narcan kit in Mason County. And you'll notice that there have been over 300 lives saved from those Narcan kits. It's a pretty incredible number. We also have our Substitutional Outreach, or our syringe exchange program, which is really our harm reduction program, bringing services to community members. We still have 3 locations that we drive our RV to every week. So we make sure folks have utensils and things to keep them safe, as well as an entry point into the system if they're ready to make those next steps. The QRT, or the Quick Response Team, is also a program that we have been a part of and helped in writing the grant and providing technical assistance. This is a program that is a partnership between Peninsula Community Health Services and the Fire Authority in North Mason, and continues to run to this day. You'll see we have the medication assisted treatment and reentry program that has grown exponentially over the last several years. We're able to provide SUD assessments for folks that are in the jail, MAT induction, case management, and then that critical piece, the reentry, getting folks connected to service, so when they get out and they set foot on the sidewalk, they can make that connection and hopefully sustain their recovery, that they were able to build a foundation while they were incarcerated. We also have the Corp implementation project. That is a great partnership currently between the Mason Health, PCHS, Fire Authority in North Mason, as well as Olympic Health and Recovery Services. The 2 main points of emphasis for this particular project have been to build our peer workforce, as well as build out our jail support program. There's also an effort to build out the peer support at Northwest Resources. This was a partnership between the Therapeutic Court and Public Health and Northwest Resources. We were also hopeful in added support for Therapeutic Court expansion, providing technical assistance, as well as on the Drug Court Policy and Planning Advisory Board. We have implemented and coordinated the Law Enforcement Assisted Diversion Program over the last several years. This has been just an incredible program. It continues to grow. Our program has been used as an example for other rural implementation projects, as well as larger communities. It's an incredible partnership with our law enforcement partners, prosecutor's office, public defender's office, and our service provider, Olympic Health and Recovery Services. And we also have the Behavioral Health Navigator program that's been running about a year now. This program supports our law enforcement agencies, both the Shelton Police Department as well as the Sheriff's Office, and is able to connect folks to services and provides real-time support to deputies and officers in the field. And that program continues to grow as well. And as we all know, resources are limited in smaller rural communities. So I really wanted to highlight that with the efforts of public health and our partners, the programs we've highlighted here, we've brought in over $5 million in Mason County over the last 5 years. I think that's pretty incredible, both state and federal dollars. You know, we've really tried to maximize our efforts and maximize the dollars we have. We've written a lot of grants and put a lot of effort into tracking down those dollars. And I think we've really put them to some great use. I wanted to just do a quick slide on next steps and point of emphasis, a lot of what we've learned over the last several years. I'm happy to announce that our Board of Commissioners gave us the final approval to move forward with our Behavioral Health and Recovery Support Transportation Program. So we are in the process of getting some signatures and moving those forward to action agenda. that's going to provide an at-will, low-barrier transportation program for folks in Mason County accessing services within Mason County as well as outside of Mason County. So getting the detox, getting the inpatient, going to outpatient services, getting out of jail, going to appointments, getting medications, all those things that are needed for folks to be successful in recovery. A lot of times transportation can be a huge barrier. So we're really excited about that program. So making sure that that continues to be an emphasis. Really truly believe we need to sustain and prioritize our criminal justice access points. So continuing to fund and grow our LEAD program as well as our Navigator program. I think there's a ton of opportunity and ability for growth there. Our law enforcement partners welcome the help. We have some incredible folks that are both in leadership and at the line level at the sheriff's office and police department. So any help that we can provide them and meeting folks where they're at, you know, and working to divert them out of the justice system, I think is critical for the success of our behavioral health response. And then our continued effort for a mental health response. A lot of us around this table know that it's been a difficult road, working on the coordination of our mental health response. So just our continued partnership with Mason Health, our law enforcement and service providers, as well as to continue to grow Olympic Health and Recovery's footprint here in Mason County. They're an incredible partner and they do some incredible work. And last but not least, I just want to continue to emphasize that because of the COSAP dollars and because of that grant, we were really able to focus a lot of my time on the system and looking at those gaps and pursuing different funding options and pursuing those connections with our local stakeholders and community members. So making sure to continue to support public health with a position for the efforts to look at things as a system so that we can continue to move forward and be successful as a community. And with that, I am done. Thank you for your time.
Thank you.
Madam Chair, can I add something?
Sure.
You know, Abe, I'm sure Abe already knows this. We talked about it a little bit. Those events that he puts on has been spectacular for this. But they not only taught our law enforcement, they taught us commissioners. Last year, because of their work, I did not administer it, but we saved a life because I had it on my motorcycle from the event that I had attended. They had given me one. I have my car now, my motorcycle, and everywhere. But their reach reaches a little farther than just law enforcement. So great job to them.
Thank you, Commissioner.
Okay, so any other questions for Abe or Lucky? No? So Lydia, does Melissa want to give her presentation?
Yep, Melissa's up next. That's
Okay.
the CHA. So Melissa, turning it over to you.
Okay, thank you. Good afternoon, everybody. Just very briefly, for those of you who don't know me, I'm Melissa Casey. I'm the health educator here at Public Health, as well as the facilitator of the Mason County Health Coalition. And as part of those duties, my role is to conduct the community health assessment and kind of lead the efforts in the community health improvement plan. So I have just a few brief slides to share with you today. I'll go ahead and pull those up. Okay, can everybody see my slides?
Yes.
Oops, I gotta go backwards. Okay, here we go. Okay, so you should all have a copy of the latest drafts of the 2021 Community Health Assessment, or the CHA, that was sent out with the Board of Health packet. Today, we're just gonna keep it really brief. I'll share some of the conclusions with you, where we have strong health outcomes and where there are still areas for improvement, as well as a few recommendations for some priorities of focus as we move into the next steps, which is actually drafting that community health improvement plan. Additionally, before I begin, I want to briefly note that due to the pandemic, much of the data that's reflected in the 2021 CHA are from 2019 and earlier. There's really only few measures where 2020 data was available. So just keeping that in mind, this CHA does not include the impacts of the pandemic, which we can really only assume and anticipate will have a much greater impact than is currently reflected here. The data will be revised in the subsequent CHAs. So the CHA is usually done every 2 to 3 years. I think just given the delay in a lot of data that was available, we may, for the next CHA, do it sooner in the 2-year period rather than 3 years. Okay, so some of the strengths. Well, first, Mason County residents are living longer. Life expectancy has improved over by 4 years in recent years, as well as premature death has also begun to decline. Graduation rates, those have increased steadily over the last decade, and surprisingly or not surprisingly, in 2020, when most education was done remotely, that is when we've actually reached our highest graduation rate in the last few years. Crime has definitely gone down, at least compared to similar counties, as well as across the state. For adults, crime has been lower than the state for some types of crime, so property crime, drug law violations, and arrest rates for youth have also decreased significantly over the last decade. Water and air quality continue to improve, at least for the few measures that are included here. So as we kind of polish up this draft and finalize the CHA, we may have a few more indicators, but at least for what's included here in the current draft, they continue to improve. It suggests that there are no major physical environment factors that negatively contribute to health in Mason County. And finally, with substance use, binge drinking, and alcohol-related crimes, those rates are low for both adults and youth, and they continue to decrease over time. So weaknesses, while this is labeled as weaknesses, I really like to kind of look at these as opportunities for improvement. This is where we can really focus our efforts when it comes to doing health improvement work, project focus going forward. To start, access to healthcare, it's not really a surprise for a small rural county. It continues to be a major barrier for Mason County. Local provider to population ratios are very large. And we know, one of the reasons for this is many residents seek primary care out of county. A lot of people go up to Kitsap, a lot of people go to Olympia. They also utilize urgent cares and emergency departments in those larger neighboring counties. So this is something that has definitely been an ongoing barrier for Mason County. Adult and youth obesity rates, as well as physical activity. Adults have exceeded the obesity rates in Mason County compared to those of neighboring counties. So the counties here that we've compared to, which are very similar to Mason County, are Grace Harbor and Lewis counties. We've exceeded obesity rates compared to those counties, as well as to the statewide rate of obesity over the last four years consistently. Youth also experience higher rates of obesity compared to other counties in the state. And not meeting physical activity recommendations. We've done okay in past years, but over the last 3 or 4 years, Mason County has doubled its rate of adults who don't meet physical activity recommendations. And similarly, only a quarter of youth meet physical activity recommendations. Sexually transmitted infections, chlamydia has nearly doubled over the last decade in Mason County, and teen birth rates have also remained high compared to similar counties as well as the state. The rate of drug overdose and opioid overdose deaths, those have increased significantly when you look at the trends by year. But I do want to note that while there was a large and sharp increase in 2019, this may potentially just be an outlier in overall trends. The cause of that 1 year increase hasn't been immediately identified, but those in behavioral health and substance use prevention work have inferred that that may be due to an increase in fentanyl use. So again, this is just something that needs to be explored and perhaps a project focus for some programs. Cigarette smoking rates, they fluctuate over time. But currently in Mason County, 1 in 5 adults are smokers, and vaping or e-cigarette use, that has really become more popular with youth, and it's increased by 22% across all grade levels. And the grade levels here that were identified are high school age kids for ages for grades 9 to 12. Again, another substance use issue with marijuana. It's higher use in adult and youth in Mason County compared to other counties, as well as statewide rates. And finally, poverty rates, while they are declining, they do still remain much higher in Mason County compared to other counties. And nearly a third of Mason County residents are housing cost burdened. So with that, we do have a few recommendations. So again, Dr. Gardner had mentioned getting back to foundational public health. I think a lot of these areas really cover that. Access to healthcare, again, is an ongoing barrier in Mason County. Conversations have continued around this for years. As a rural county, access to healthcare, it's not a new priority. But due to the COVID-19 pandemic, I think an even greater burden has been placed on our local health system. So it's definitely something that we want to continue to focus on as we move into the community health improvement plan. Empowered families, this kind of covers a few things. David mentioned earlier and made a reference to losing WIC. We've also lost Planned Parenthood. So this is kind of where some of those quantitative data points, so sexually transmitted infections, teen births, access to prenatal care, these are the types of numbers that we've looked at, but the qualitative balance here is really kind of knowing the narrative of what's going on in our community. And the loss of those two programs in entities, Planned Parenthood and WIC, those will definitely create further barriers in accessing reliable and confidential testing for things like STI, pregnancy, as well as reduce referrals to other family planning services, healthy food and nutrition education, prenatal care, breastfeeding education. The Empowered Families Work Group in particular of the Health Coalition can definitely prioritize establishing perhaps a low barrier and multicultural early reproductive health service to take place to kind of fill the gap that's been created by losing these programs and provide continuity of services to our community because we do have higher rates of sexually transmitted infections, teen pregnancy, as well as lower rates of early prenatal care. Finally, healthy living. So as I mentioned earlier, obesity, very high in Mason County in both youth and adults is in comparison to other counties as well as the state. Obesity increases the risk for chronic health conditions, heart disease, type 2 diabetes, cancer, stroke, and we targeting interventions with youth in particular can really help prevent those chronic diseases later in life. So interventions that perhaps the Health Coalition and the work groups can focus on may be extending nutrition education in schools, targeting food insecurity by increasing access to healthy foods, and establishing more physical activity programs. Behavioral health and housing, as you saw with Abe's and Lucky's presentation, these are areas where work continues to be ongoing, and there's certainly an additional need and an ongoing need for these. So finally, the next step, that was a very brief overview of some of the findings of the community health assessment for 2021. The next steps is the Mason Matters Board of Directors will be meeting later this week. they provide the oversight as well as act as the fiscal arm of the Health Coalition. So we'll really kind of begin to dig deep into the community health improvement plan, really kind of set the stage for that. And plan out what the work groups are going to be. Once we've kind of completed that initial phase, then we can finally convene the whole Mason County Health Coalition and start to work into implementation. And, you know, as an example, some of these recommendations that we've made previously, how can we actually turn that into action? How can we allocate dollars towards doing work like that? And healthymasoncounty.com. This is kind of the hub of all things community health related in Mason County. Currently, as I mentioned earlier, behavioral health and housing. These are two sectors where work has been ongoing. There's been work to really move the needle on improvement in these areas. But the idea and the goal is that this website is really going to become a hub of information for all the different health priorities that we cover in our community health improvement work. The 2021 CHA, once approved and published, will be available on this website. So this is definitely going to continue to be a work in progress. And that is all that I have. So thank you so much for your time. If you have any questions about the assessment, if you have questions about joining the Health Coalition, or you would like to serve on a particular work group, please don't hesitate to reach out. I would be glad to chat with you. Thank you.
Any quick questions for Melissa right now? Okay,
Great website, by the way.
go ahead.
Oh, I said the great website, by the way. It has a lot of resources in there. So.
It does. Okay, so the next is the presentation by you, Sharon. For the
And I think for me, I'm going to, there's still, it's like a work in progress, really.
yeah,
We're waiting for the tribes to give us their information. So if Dave wants to add more to it, I would say that we can just push this off until we get more information from the tribes.
you're muted, Dave.
Yeah, also I click the little button. Yeah, so with that, Commissioner Trask, as she mentioned, we're waiting for the tribes for their two pieces. There's been some discussion with the American Indian Health Coalition about helping the tribes find people to put towards our board. The biggest change, there's several changes we'll need to make, and what I'm looking for is basically just kind of a nod from the board. This is the direction we want you to go. In order to make us work for House Bill 1152, we'll need to add 3 users of public health in order to balance our 3 medical, our 3 stakeholders. We've got commissioners and city; those are covered. But in order to make it all work out, we'll have to add 3 people from public health users. So I'll come back with a recommendation on that. And then looking at our current health department in chapter 2.14 of our county code, we're going to need to change the piece on the chairman. And I would say we probably ought to look at the piece on the quorum. So I'll make some recommendations, and then a piece on term limits for those that aren't elected. So we'll have term limits go with that. And what I would like, if you're good with it, I'll go ahead and go draft something for this. Then for the next board of health meeting, we can go through it. If that works, then it'll need to go to the county commissioners for a hearing, and then it can become code. We have to have all this done by July. We've got time, but there is a process that we'll wind up going through in order to make this work. And then we can wind up changing it all next year when they open this bill back up again. So,
Well, I'm excited that we have conversation with the tribes.
right, and yes, and that's moving forward.
Because we've been trying that for a while, but not been very successful. So that'd be great.
Right. And I think it's important to note too that some of our stakeholders can be just looking real quick with here, nonprofits, active reserve or retired military, business community, and environmental public health So there's,
Right.
it opens the door for quite a few people to come and sit on the board with us.
That sounds exciting. I'm all for going forward with it. How does everybody else feel?
That sounds good to me.
Okay. So
No issues.
okay, I guess that's your, go ahead, Dave.
Okay, will do.
Okay, so I think the only other thing is public comment. Jean, are you still there?
I know,
I am here. Yes.
Jean, do you want me
Oh,
to kind of say what we talked about today?
I thought it was a very good meeting.
Well, thank
Oh,
you.
I can't get my picture on. I can't
That's
get the
okay.
mouse to work, but I thought it was a very, very productive meeting. I'm so glad that Dr. Gardner is here.
Did you have any other comments?
Oh, not really, because it was so comprehensive, and I really appreciated the presentation that Gabe and Lucky gave, and you know, there's things they're looking up. There's things to look forward to.
Okay. Okay, can I get a motion to adjourn then?
So moved.
Second? Do I hear a second?
Second.
Okay, all those in favor?
Aye.
Aye.
Okay, and I'm sure nobody's opposed, but okay, I will see you, I guess, in 2 months.